Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is brought to you by AACN's Clinical Scene Investigator Academy, providing the knowledge, skills, and tools to lead innovation, with information available at www.aacn.org/CSIAACN. Now here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Dr. Vicki Good, AACN's Chief Clinical Officer, and I am joined by my colleague and co-host, Andrea Schmidt, a Clinical Practice Specialist.
Hi, welcome to today's podcast.
Andrea, we know that nurses who work the night shift often face biological uphill battle. Between the hours of 2 and 6 a.m., the human body hits its circadian low point where the drive for wakefulness bottoms out and sleep pressures become undeniable. For decades, the industry standard was to power through this, despite the evidence linking night shift sleepiness to increased risk of patient errors, occupational injuries, and drowsy driving on the commute home. But the culture is starting to shift. We're moving from the view that fatigue is a badge of honor to treating it as a safety risk that requires evidence-based countermeasures.
Vicki, all of that is so true, and I'm sure that anybody who's ever worked night shift will totally agree. So today we're going to explore actionable solutions to this problem. We're going to be discussing best practices for night shift wellness. Specifically, we're going to be looking at the use of a toolkit designed to help units overcome logistical and cultural barriers to rest. So, joining us to unpack this vital work are two leaders who have brought this concept from research to reality. Dr. Pamela Hines, Director of the Department of Nursing Research and Quality Outcomes at Children's National Health System, and PJ Eschbach, a key partner advocating for this initiative. Pam and PJ, welcome. And can you each share your nursing journey with our audience?
Thank you for the warm welcome from both of you. PJ, would you like to go first?
Sure. I have been a critical care nurse for 49 years. I did adults for 15 years, and then I switched to pediatrics. I've worked nights for about 30 of those years, or maybe 25. Yeah, and I'm a bedside nurse. Hardcore bedside nurse. So,
Love it.
Yep.
And highly regarded and liked at our institution. I'm Pam Hines, and I am now a nurse scientist, but I have been a nurse for about 45 years and did 5 years of nights and was convinced that those of us who worked on nights had the best sense of humor, but it didn't translate into telling anyone what was so funny on nights to anyone who worked days. We became very concerned together about tiredness on the night shift. And I really want to pick up on Dr. Good's opening comment about night shift being against some biologic clocks. There really are morning doves, and there really are night owls. And if you are a morning dove working, the night shift is against your normal biologic clock. And so we know that working nights is a challenge, and there are health challenges to working the night shift, fatigue being a primary symptom. It's not the only symptom. We know from a limited number of studies that those who work the night shift are more vulnerable to sadness, even depression, worries, anxiety. And there's a very small number of studies that suggest, not confirmed, there may be a slightly higher risk of breast cancer for those of us who work the night shift.
Yeah.
And because of that, PJ and I honestly feel that it is our duty to support those who work the night shift, to focus on their wellness. And that's really what helped to take us to studying fatigue in night shift employees, particularly nurses, and to look together with a team at the literature available to us in terms of what we could do to minimize fatigue on the night shift.
So Pam, to further set the stage, could you describe why your hospital transformed night shift fatigue from a standard job expectation to a critical safety concern?
Oh, it's the perfect question. Like all hospitals, we have a rule that says if you sleep during your shift, you are vulnerable to losing your position. We had looked at a number of sources about tiredness on the night shift, and we had a hospital near us that suffered the loss of an RN on her way home when she fell asleep at the wheel. Very concerning for us. We then began a literature search with a known expert from the University of Maryland, Dr. Jean Geiger Brown.
Mm.
Carefully examined the literature, went back to our leadership in nursing, the division of nursing, always keeping on their leadership agenda so they would know what we were doing. And we presented our preliminary findings. And I think PJ could tell you about when we met, how we met, what we focused on, because she really represented the night shift on our project team. And then we asked if the leadership group might charge us with doing something about the findings that we had. And in particular, we wanted to create a demonstration project on one of our units. We wanted to learn, could we make a difference? And we had a very brave director of nursing for the hematology oncology unit, that's Rose Zealous, who wanted to see if we could do something. And so we did our demonstration project on that unit. Let PJ talk a little bit, though, about how we met, when we met, who formed our committee, and how we then even brought in public relations and HR so that they would know what we were doing. PJ, do you want to say anything about our team?
So I think we first had the HEMOC unit did their pilot,
Mm-hmm.
and then after that, it was successful, and they were very happy. And then I believe it was you and I think it was you that reached out and asked, "Does anybody want to be on this committee?" And I'm like, this is the committee for me. I was so happy. And I'd also gotten, in our discussions, like in break in the night, how tired we were and how we wish we could nap and we wish we had the facilities to nap and we wish, and it was a discussion for a long time. So it was timely. Then you had the committee, we met, and it was a pretty good group, night shift. And that's how I met.
It was fun. We
Yeah.
met the
Oh,
hour
yeah.
before the night shift.
Yeah, that's right.
Yeah, and kept meeting repeatedly until we had weighed all the evidence we could, and we came up with proposed guidelines of how we might do this in a way that would be safe, monitored, measured. And we started out with a baseline survey because we wanted to know how serious
Yeah.
is this issue?
Mhm.
The survey was huge, I think.
It was, wasn't it?
Huge.
Yeah.
Yeah.
Over
Very
180
eye-opening.
nurses. Yeah,
Mhm.
and here is a very sensitive topic because of that rule that if you were caught napping, you could lose your position.
Mhm.
So it was a very anonymous survey. No way could we or did we want to track who had responded. We just needed the data. And in that survey, we learned about the high proportion of nurses who were feeling sleepy on the way home, who were falling asleep at stoplights, stop signs, who woke up finding themselves drifting across 3 lanes of highway, and so on, who could not recall exactly what they had said at the time of end of shift report, and they felt so badly.
Yeah.
With those data, we took those back to our leadership, a very sensitive leadership that wanted to do something about this. And in bringing the findings to leadership, we said, wouldn't you like to charge our working group with coming up with an intervention that we could take across units that are interested? Charge us with being responsible for doing that. And very fortunately, we had nursing leadership that said we would like to see if this could make a difference. And with that, we made it an option. We worked with all of our directors about the data, baseline data, literature data, and what we believed we could make better. Our committee, PJ included, worked with environmental services to say we're looking for space. The directors helped us to find space. Security worked with us because we wanted safe space. You could sleep in an area where they could see and protect you. And that then became a network of effort to make this happen. I think PJ and I would tell you that not every director felt comfortable with this. And we understood that that was a radical shift in how we had done things. We had two directors who wanted to wait and see what happened on the other units. We thought that was reasonable. We had one unit where it was very challenging to find space at night that could be converted to sleep space. PJ, would you share what you did on CICU? You were brilliant and really made
Well,
it happen.
ah, we we had to get creative with our space. And I would say out of all the challenges, that has been the biggest challenge because we started out in one space and then we kind of got booted out of there because I think the physicians took that over and we're like, well, we're going to find another space. So then we moved into like if there were empty patient rooms, they have couches in the back. So then we did that, and that was really nice until somebody left the linen, and then we all got in trouble for that. So then we were like, okay, well now there's a space for physicians, a media center that doesn't get used a lot at night. So then we went there. We moved around a bit. We do now have a respite room that has two spots designed for, you could accommodate two nurses, but if five of you go on break, well, that's not going to work. Depending on who wants to nap. Not everybody naps, and not every night they nap. But we let whoever's covering know where we're going. I'm going to go take a nap, and and when we hand off, so that the other patient's covered. But we've had to move around quite a bit, and I would say that's our biggest challenge. But we've never not found space, believe me.
I,
We've gotten very creative with where we go.
Of course,
I
leave it
like
up
to,
to a
Even the
nurse. We're
tele
going to create a solution.
And the tele room, they don't use it at night. Looks pretty inviting. I
Yeah.
can imagine. We get pretty
I,
creative.
I'd like
Yeah.
to really pick up on a number of things that PJ said. We wanted the staff to feel safe in
Yeah,
doing
Right.
this, not just physically, but role-wise. So we told them that we would never monitor who took a nap, how often they took a nap. It was to be a 30-minute nap, and it was to be any time, preferably from midnight until 4 a.m. Those are the chief hours that are the hardest on night shift workers. We have held to that, and we've been napping now, BJ, 7 years or so. Yeah.
yeah.
And I can say to you, we've had one complaint in all of 7 years, and it was from one unit that explained they had a nurse who slept too long, went over the 30 minutes, and we were able to help with that. I think it's really important to know that we said, as we rolled out the napping initiative, that we must all come to the night shift prepared not to nap, that there is no guarantee to nap. The commitment is that we all come prepared to work our best, our hardest for our 12-hour shift. If by chance the internal judgment on that unit from who is in charge on that night shift is that napping can occur, handoffs can occur, then the decision is made who can nap. And it's who needs, who volunteers, etc. to nap. And it's worked out amazingly well. So well that at one point, 10 of our 14 units were napping. At one point, we lost 2 of those units, and then we got to 12 of 14 units. And that included our emergency crew that was flying our helicopters. So when I say that we've been very fortunate with no issues, I want to add to that that the project team did a follow-up survey after the baseline before we initiated napping. And I'm excited about some of the amazingly positive outcomes that were reported. I want to emphasize this is not a longitudinal study. It was different nurses who had become a part of us since the year and a half of implementing nursing. So many of the same nurses participated, but not all. So I wouldn't call it a longitudinal survey. I would call it cross-sectional. And I would share with you that several major important changes came out and several things were reported as getting worse. So I'm going to explain what I think could explain that. Um, what got better, but not good enough, was safe driving on the way home. What got better was reporting off at end of shift, being able to remember what was said, feeling better about self and others, not seeing as many of your colleagues being tired on the shift. Several things got reported as being worse, and I'm going to suggest to you perhaps the reason that was a finding on 3 items is because the nurses felt more comfortable telling us what it was like to work the night shift and what was harder. And maybe we don't feel comfortable enough saying what's really true until we know that people are really listening and that they want to make it better. I think both PJ and I would share with you that those survey findings taught us that nurse napping helps a lot, but it's not enough. I would share with you that I have done night shift nursing research rounds, and on those rounds, we have talked about napping as one of our study initiatives. Shortly after the first year of napping initiative, I was doing those rounds, and I met a nurse on one of our units who said to me, I heard that Children's National Hospital in Washington, D.C. had napping, and I wanted to be at a hospital that cared about its night shift nurses. So I applied and got a job at Children's National Hospital in Washington, D.C. She was the first nurse to tell me that, but 2 others on subsequent shifts also told me that. So there are nurses who either want to work nights or who need to work nights. We need to make them safe. And so that has been a very welcomed, spontaneous, unmeasured feedback for us about the napping initiative. I think we would also tell you that we know napping is not enough. It's good for many. It's not good for all. And I say that because 2 and perhaps 3 of our nurses reported what's called sleep inertia. Once you fall asleep, it's very hard to wake up. And of course, we're expecting you to sleep and wake up in 30 minutes. So for them, waking up in a 30-minute time block became almost a feeling of illness.
I
So they
have heard
could
that
not.
too.
Yeah.
From
So they
some.
could not continue with napping.
Right. They felt
Um,
worse when they napped, but
yeah.
I have heard that.
And PJ, the other thing that I often hear is some newer nurses saying, "I don't want to nap because the more senior nurses might think I'm a wimp, I'm weak, I can't do the shift." So we know that that can be another
Oh my
reason.
gosh. Well, I'm the oldest nurse on the unit, so, and I'm part of the, I'm a, napping is, I love, so I haven't heard that, but I don't suppose I would. They're not going to say that to me. But,
Right.
aw, that's a shame.
Well, let's
We invite
let
it, we encourage it, so.
yeah. Yeah, let's shift the dialogue a little and talk about your advice for others because clearly, one thing that I absolutely love is the fact that you've put a lot of this decision making at the bedside. So
Yes.
nurses can make that decision, the unit can make that decision on when it's
Mhm.
appropriate and not appropriate, and that's so critical. And that's one thing that we advocate for hugely with healthy work environments is the nurses have to be involved in those
Mhm.
decisions. But I want to switch to like, what advice do you have for folks? Because I know the HR issue is a huge thing to overcome because pretty much every single hospital in the nation has in their policies, thou shalt not sleep on the job.
Yeah.
So what is your advice for
Mhm.
someone wanting to start this initiative?
We actually believe that because we were doing something that went against rules and culture, that from the very beginning, as we spoke to nursing leadership, we needed to be including HR. We have a good relationship with our HR department. We invited them to meetings. We had them speak to what their interpretation was of our initiative and what they could consider as approvable. So we did that from the very beginning. And then when we wrote the guidelines for our napping toolkit, we sent the guidelines to them.
Mhm.
We had a point person specifically to work with us on the napping initiative. And that relationship was very positive and continues to be that way. So, from my perspective, this is not the time to take anyone by surprise. It's the time to bring everybody along with you and repeatedly give updates. It's also the time to start with a person who's in a top leadership position, as we did, who wants to do this. That person is going to champion it and is really going to do all they can to give you an honest test of whether or not this can work. At the same time point that we at Children's National were starting this initiative, two other hospitals in a sister state were also trying, forgive me, three. None of the three could get it off the ground. And they just talked about the barriers, making them not want to continue to pursue it. So to set the stage, then we would, I believe, lean in the direction of don't try to do house-wide. Take one unit where you have a champion top leader who wants to honestly try this. We would share anything that we have done, like our toolkit, advice, experience. We want this to be successful. This is a matter to celebrate together. We felt so great about our early findings and then our subsequent survey findings that we went to others in our hospital who also worked the 12-hour shift to see if they might like to join in. And that was a very positive experience as well. We also went to a department that frequently has overtime to ask if they too might like to join us in this initiative. So we wanted it to be as inclusive as it could be. And I actually think there's a benefit to doing that.
I think it might be helpful, like for us, the data collection before we ever started and getting nurses' views on tiredness. And we have a lot of commuters, and I think a lot of hospitals have commuters. And, if you getting that data was so eye-opening for me. I'm like, oh my gosh, this, particularly the driving, and even like when you give report and you see the nurse falling asleep,
Mhm.
and you do while they're giving report, like this is how are they going to drive? How are they going to, and so it becomes a safety issue. So I think for other hospitals, if they can do, I agree with Pam. If you can get everybody on board and
Mm.
include HR, it's really, really important. Um, and not only that, they have some insight that I don't have. I don't work in HR, but we need them. And
Yeah.
also, it's a good way to retain nurses. I mean, you can look at it.
Mhm. Mhm.
So it's that kind of thing too. But I felt like collecting the data was key. I really felt like, and when we presented all that data to the nurse leadership, they were like, oh my gosh. It
Mhm.
was eye-opening and scary, actually.
Right.
And hard to ignore, huh, PJ? I mean,
Yeah,
so yeah,
yeah,
well stated, PJ. And I think even your closest colleagues, non-nurses, such as physicians, will find this idea of napping to be so different that it's kind of startling to them. Now, you and I might say, but you nap on the night shift when you're covering. Um, True, but that's an established tradition.
right.
It is not the same for nursing. So we learned very quickly on that we needed to prepare our physician colleagues. And I remember being invited by my request to the executive board for our physicians. This is a really neat relationship, close colleagues. We do well together. So here I am presenting that we're going into napping and what we've done to prepare. They were not at all being difficult, but they were stunned. And they said to me, what are we going to say to families on the night shift when their nurse is napping? And I said, oh, the
Right.
very same thing you say when you cover each other,
Mm-hmm.
that another nurse is covering at this moment because that nurse is on break. And that's a truthful response. But it was good for us to learn. Don't assume that others understand why we're doing this for nursing. So it's good then in any activation plan of an initiative related to napping to think of all your partners and how you can reach out to them to prepare them for what is coming, to learn what their concerns might be, and to work to show that you are addressing those.
So I'm curious, Pam, have other disciplines picked this up? Because pharmacy works all night, respiratory therapy works all
Yeah.
night. Have any of the other disciplines picked it up?
No, it's interesting to us because we especially reached out to one of those to see if they could possibly join us. I'm hopeful that in this new year, this initiative will be seen as for all. We have been able to expand it to patient technicians, and we really feel very good about that. And it's interesting how they work with the RNs to make sure that equally they all get considered for the napping slots and they work it out and take turns. So for us, that's a model of how it can work with other disciplines. There are other areas in the hospital that could be used for napping for those professions that you've mentioned, Dr. Good. So we know that part of what would be needed, we could help to address.
This is such a great project, and I'm so thankful that you've taken this on for nurses and their safety and their well-being, and also that of patients. And I have so many questions, right? I don't even know where to start. But one thing you mentioned, PJ, was that it was eye-opening for leaders and stunning, I think was the word you used. And it made me think, if they can't make it through report, how many times is there the expectation stay after for the meeting too?
Yeah.
So not only have you worked
Ah,
12 hours,
oh yeah, that's a joke amongst us. We're like said, yeah, no.
and then now it's like, oh, we have our shared governance at 8 o'clock in the morning. Stay for that, and that's 2 hours, or go
And
to
you
a
see
committee
them,
meeting.
they're asleep. They're asleep.
And what are they gaining from it? Nothing. And I think we're putting them at more danger. And I really think that that's also something. It's like maybe we shouldn't do that. Or if you work nights, you don't come to the meeting. You go home, you go to sleep, right? I just feel like there's so many things that can spin off of this.
We feel like the stepchildren sometimes. Like,
You
yeah, we do.
had mentioned the toolkit, one of you, that you had developed this toolkit.
And yeah.
So I'm very curious about exactly what it is. So what are the elements of it that, could be potentially shared at some point, or, who was involved in the development of this toolkit?
Our whole team was involved in that. We used some of the literature that we had reviewed. We reached out to NIOSH, to ANA to get their standards related to fatigue, and we relied upon those. We included our guidelines, such as needing to come fully prepared not to nap and to be fully ready for shift. We included what needed to be addressed for safety and the careful handoff that PJ mentioned, etc. We shared every parameter that we had developed or had gleaned from the literature. So all of that is in the toolkit. We have some links to publications that we had done, that kind of thing. The Joint Commission has a standard related to fatigue and sleepiness. So all of that we have cited. The IOM has a report on nurses and safety, the environment of care. All of that we cited in there, and we're very happy to share that. We are getting ready to do an update on that toolkit, and one of our shared decision-making councils will be involved in that. The literature has expanded slightly on napping and the night shift and wellness and the night shift. I think we mentioned to you that we've learned that napping is not the only tool that should be available to our night shift employees. And we did a wellness study last year to add on to napping, and we compared mindfulness. We purchased a mindfulness app for our night shift nurses, and we also developed a physical activity program from our physical therapist. So we compared 8 weeks of mindfulness against the physical activity, and both arms got sleep hygiene. So that was the intervention comparison. And then we flipped so that every nurse got both of the interventions along with sleep hygiene. In the end, we found out differences, and um, we had nurses who said, "You changed my life. You made it so much better. I can sleep now," because some of the physical activities and mindfulness activities were meant to use at work, and those that we selected were meant to help keep you alert. Those that we selected for at home were meant to help you go to sleep. And there are such differences. So all of that was good. We found out that professional compassion increased. We found that fatigue decreased. But I also would have to share with you that we also lost people from the study. So we started out with 80 nurses and we ended up with just under 40. So clearly, as the researcher, I made a mistake in the study design. I am asked too much. I had 8 weeks of mindfulness, 8 weeks of physical activity. We should have done it and could have found a lot more if we had abbreviated that, we think, maybe to 3 weeks. So if anyone would like to take on that study design, we're happy to share with you what we did. We have published that. We've learned a lot about how not to do it as well as what to do. But we did learn that mindfulness for those who stayed in the study was the preferred activity. By far, sleep hygiene was what most people practiced. And that's good for all of us to know that people working the night shift are so concerned about sleepiness, fatigue. They're willing to try a new habit. We just have to, as researchers, make it more doable and not have such a fancy design that no one wants to do it, or very few want to do it. So good lesson learned.
Yeah, you got to keep it simple.
Yes. Such a great, concept. Now, I do have one question. It's going to be a devil's advocate type of question. So we know many nurses out there are going to think, I can't even go to the bathroom. I can't get a meal break. How am I going to nap?
Mhm.
What happens if they do nap? Do they still get a meal break? Right. So I'm curious if you can explain how that works and how naysayers may, actually take the plunge and be willing to give up their phone, give up control to take that
Yeah,
break.
yeah.
Our breaks
PJ?
are an hour. So you can eat and sleep. You can. You have time to do both. So those people that nap, that's what they do. If it's not safe to turn over care, because you're for multitude of reasons, we're in an ICU, our kids are really sick, or somebody's crashing or coding, then we
Mhm.
don't go. I mean, really, I'm not gonna, our patients come first. So there is that. But we do get an hour, and the research supports the 30-minute nap. So you start getting longer than that. I think you do get more of that sleep inertia that
Mhm.
Pam was talking about. And that's what the studies supported. So people usually eat something, and it may be a matter, it's not a, it certainly isn't, dinner at the Ritz here. It's a, for me, it's a protein shake or a protein bar and something, something else, but nothing fancy, and then they nap. So that's how we work it.
I love that. And PJ, thanks. I want to add on to that just a bit, and that is that in the wellness study that we concluded last year with mindfulness being compared to physical activity, there was an item exactly about what you mentioned, Andrea, about taking a break, getting your meal. And those nurses who reported they always took their break had much better scores in terms of fatigue, wellness, compassion. Those who never to rarely took a break had concerning scores, really supporting that even though there are such cultures, we have them too, and they're very strong. They do need to be addressed if we really want to pay attention to the wellness of our night shift employees. Now, I would say to you that we shouldn't ever want a night shift wellness program to be dependent upon a study, like one study, the next study. And I'm very excited for many reasons about Children's National Hospital. And one of them is we have a wellness leader, and we are now working with her to translate what we've done into an ongoing night shift wellness program. So you're not dependent on a study. You're really fully supported in an ongoing manner by initiatives that are specifically labeled night shift wellness. So we're early in that process, but I'm very excited that we now have that kind of opportunity to really demonstrate our commitment to the wellness of our night shift employees.
That's amazing. My one last question, and then we're going to conclude, is having an hour break is more on the rare side. Many hospitals, it's just 30 minutes. So how would you suggest that a hospital or a unit manages that when they only are allotted 30 minutes? Maybe they get a 15-minute, on one side of their shift, but how do you suggest?
So can't they eat in one of the 15 minutes and then do the 30-minute nap? They can't do that?
I don't know, maybe. I think it just depends, but.
Or couldn't they combine them? I mean, we don't get the 15-minute, we get one hour.
Right.
Yeah.
Well, and I think that's where you put that in the hands of the decision makers and say, how do you want to handle your breaks? Because there are labor laws around,
Right.
how much break you're allotted. And I think depending on the state, it's 30 minutes plus usually 2 15-minute breaks, which comes to your hour. So I think there are and that's where it's so critically important to put that in the hands of the staff that are doing the work.
Agree. And the leaders at that organization too, what they're going to, permit or how they want to roll it out. So thank you for that. I was just thought it might be an important question to ask for units who go, we don't get an hour break. How would we do this?
Well, even if you get 45 minutes, you could do a nap.
Right.
You could eat a snack and do a nap. You could, you may have to get creative with it, but it's doable.
Well, I just want to thank both of you for sharing tremendous insight, because I think that's the important thing about our podcast is how do we get practical tools in the hands of our listeners? And you've really provided a lot of practical tools to really implement research, because I think we often think of research as this, scary thing that happens and we put it on the shelf, and you've brought it to light and given us practical tips. So thank you so much for sharing your knowledge and your expertise and all of your experience with us.
You're welcome.
I really thank you for caring so much about the members of your organization. The fact that you would have this as a topic speaks quite well to your caring about your members.
Well, it's critically important, and as somebody that worked night shift for many, many years, it's a passion of mine, because it's a whole different animal out there, being on the night shift. So it's a whole different way of life and how you have to think about things. So I am just thankful for both of you and thankful for our listeners today. And we would like to hear your feedback on this episode and any feedback on future episodes at podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's Clinical Scene Investigator Academy, providing the knowledge, skills, and tools to lead innovation, with information available at www.aacn.org/CSIAACN.